Hello, my name is Max Spaderna. I'm an assistant professor of psychiatry and a board-certified physician in addiction medicine at the University of Maryland School of Medicine. I'd like to discuss the recently published article in Health Affairs I co-authored with Annabelle Belcher, also an assistant professor of psychiatry at the University of Maryland School of Medicine and a researcher in addiction medicine, titled Telemedicine Buprenorphine Access for Incarcerated People, Lessons Learned from Maryland's Rural Jails. Incarcerated Americans have been disproportionately affected by the opioid crisis, yet less than one-third of jails offer FDA-approved medications for opioid use disorder. These gold standard treatments, which include methadone, buprenorphine, and naltrexone, have been shown to reduce mortality, recidivism, and health care utilization for incarcerated individuals with opioid use disorder. There is a great need to expand access to treatment for incarcerated people who are at the highest risk of overdose, and this is especially true in rural, geographically remote areas where addiction medicine providers are scarce. Telemedicine provides a low-barrier clinical platform that resolves issues of provider availability in poorly resourced, geographically remote areas. In 2020, with the support of seed funding from the Foundation for Opioid Response Efforts, and in the midst of the COVID-19 public health emergency, our team at the University of Maryland initiated a new clinical program to provide telemedicine-based buprenorphine for opioid use disorder for incarcerated patients at a rural Maryland jail. It was also during this time that the state of Maryland had just passed House Bill 116, which required that all local jails and detention centers provide access to all 3 FDA-approved medications for opioid use disorder. Since then, our team has expanded greatly, and we are now the main buprenorphine provider for 8 jails and detention centers in rural jurisdictions across Maryland. For context, there are 18 jurisdictions designated as rural, so our program provides coverage for a little more than 40% of Maryland's rural jurisdictions. As we write in the article, as of November 2024, our team has treated 750 patients across all the jail sites. Nearly 3/5 of these patients started buprenorphine during their incarceration, and 94% were retained in treatment throughout their incarceration. Additionally, patients in our program receive prescriptions for buprenorphine after their release from jail to ensure they have medication to bridge them until they start treatment with a provider in the community. Despite our successes, implementing our program has not been without its challenges. While each jail has its own unique culture that affected our implementation efforts, most of the barriers we faced were rooted in a misunderstanding of the goals of treatment with medications for opioid use disorder. This taught us the importance of collaborating with jail staff and engaging them early as stakeholders in the program. Regularly scheduled check-in meetings with staff and the use of a HIPAA-compliant Microsoft Teams chat platform ensure we have an open line of communication with jail staff for troubleshooting and sharing information. In addition, our team experienced challenges optimizing buprenorphines in the jail and making sure patients receive buprenorphine prescriptions after their release. This taught us the importance of keeping track of court dates and proactively starting discharge planning right from the onset of treatment. Our experiences underscore that successfully implementing telemedicine-based buprenorphine treatment in jails is far from a plug-and-play solution. The adage, if you've worked in one jail, you've only worked in one jail, is not an admission of defeat, but a crucial directive that success hinges on a willingness to deeply understand and adapt to the unique ecosystem of each individual jail. Efforts to expand access to buprenorphine in jails requires much more than just proficient telehealth technology. They require dedicated efforts to build and maintain robust trust-based partnerships with jail staff, flexible service models tailored to the specific operational realities, resources, and population needs of each jail, and proactively addressing the challenges inherent in the remote service delivery of opioid use disorder treatment. Our hope is that our team's experience of establishing new telemedicine-based clinical treatment for opioid use disorder will encourage other providers wishing to do the same. To learn more about our experience with providing telemedicine-based buprenorphine treatment in rural jails, you can read the September 2nd Health Affairs theme issue on the opioid crisis. Thank you for your interest.